Hey guys, welcome back. Today I want to share with you, I want to introduce you to Dr. Joe. He's a clinical pharmacist in community hospital, and I want to ask him to kind of talk about his day-to-day and what that looks like as a internal medicine clinical pharmacist. Before I go further, I'll let him introduce himself.
Hi, I'm Jimmy Doe. I'm a clinical pharmacist. I've graduated from the University of Houston back in 2012 and pursued residency program. Was let go earlier, but landed a staff position pharmacist and then transitioned to a clinical pharmacist.
Wow, that was like so I'm going to break that down for you guys. Okay, so first of all, so he was let go of a residency program but was able to obtain an evening staff position. So how did you prepare yourself into the clinical role?
So during that time, there was only one clinical pharmacist at the time. Managing is a fairly new hospital. Low number of beds, but during that time, I found opportunities to kind of build myself clinically from a staff position, area. And of course, keeping up to date with the literature is a big thing, because in order to make interventions, you need to know what is actually recommended out there.
Mm-hmm.
And so during order verification, making those interventions, not just letting, drugs be approved that one could potentially harm patients, especially given in the evening, verifying orders. An evening order is put in, you don't want to call the doctor and get them upset because maybe they're at home having dinner with their family.
Mm-hmm.
Patient safety, looking for interventions. Also doing little projects. Of course, as a staff pharmacist during that time, I wasn't involved with any committees or anything, but I saw opportunities for improvement around the department. And so I was looking for opportunities where we can improve, whether it's workflow. At that time, we had just started the heparin consult per pharmacy, where pharmacy is dosing the heparin drips for these patients. And so, I saw areas of opportunity that I was collecting data on the background just to kind of present when the time came. So I was just looking for opportunities to be able to provide improvements for the department as well as clinically for myself. And so
you were saying that you had some opportunities that you identified to have a workflow. How did you leverage that to like a management?
So I first, collected data to kind of show that, these are areas of improvement that we can have. And of course, I presented to the clinical pharmacist that was managing all the clinical aspects of our pharmacy department at that time. And she presented also to our director as well. And so, just making interventions and finding opportunities to kind of improve myself. And so I started back in May as the evening staff pharmacist. In November, this one clinical pharmacist decided to take on a different job opportunity, which opened the doors for me. Again, I didn't complete a residency program to its full completion date. I did complete 9 months of it, but when the time arose, of course, I applied for that position, supplementing my portfolio with everything that I've done through the department. One is showcasing the interventions that I made, because as a pharmacist, we're able to track our own interventions and present them. And so I had that information. The director already had that information as well. So I applied, and we kind of discussed, and my director at the time, or my director, felt that you completed 9 months of residency. In his eyes, I completed the program. I got what I needed out of the residency program.
Which is the drive, right? Like people are saying sometimes 1 year of residency equal 3 years of working, and just a sense of it being that you really have that drive, and you're constantly learning and working and just really trying to excel. So I believe in his view, and I agree with that. So how did it feel when you step into a clinical pharmacist role?
So it was pretty tough because now I'm the only clinical pharmacist in the hospital. So of course I was involved with committees as well in the hospital, which the first time I ever been. So I was going to meetings and it's very different to kind of get into that because I would ask my director, okay, so what do I do now? Where do I get the training to do what I need to do? But at the time I transitioned, the clinical pharmacist had already left, so they couldn't offer me any insight. But I kept in touch. I had their cell phone, so I kind of went back and forth. Okay, so what was your day-to-day like?
Yeah. You didn't even have that at all.
Yeah, I didn't even have that at all. Okay. So it was pretty, but fortunately I started getting into the groove of things and pretty much had to kind of carve my own day-to-day out. Fortunately, my director is not like micromanager, exactly. And so as long as I got the job done, clinical interventions, clinical initiatives, making sure that as a department we're doing our clinical interventions and initiatives, then he was okay.
Yeah. So it sounds like you went into it kind of another steep learning curve, right? From evening pharmacist, which kind of the workflow and the lay of the land, but now you step into another career ladder. What was the most challenging for you from a staff to a clinical?
The most challenging was to build rapport with people outside of the pharmacy department. As an evening staff pharmacist, I was pretty much secluded in central pharmacy. As a clinical pharmacist, I was pretty much the face of pharmacy outside of the department. So building relationships with the physicians, the nursing managers, the nurses on the floor, and of course, showing that I am a confident and competent clinical pharmacist now, because I'm kind of just jumped into this role, and anyone that was new would be like, okay, who's this new guy on the block,
Yeah.
And so it took some time, but I was able to develop that relationship with the physicians, and at that time I was responsible for the ICU primarily, so I would go on the daily rounds, and the intensivist at that time was very for lack of better terms, intense with me, because he didn't know me at the time. He didn't know what I had to offer to the rounding services.
And how did that go?
Went well. He got to the point where he would call me, and I was able to make recommendations that he was on board, fully approving. And so it was kind of a back and forth relationship where he would call me, I would call him. And
so going from finishing 9 months of residency to a staff position, now to go full-blown clinical with administrative work, because you go to committees, and ICU. How did you prepare yourself for ICU rounds? Because when you do residency, you get a peek into what ICU, maybe 1 or 2 rotation. When you, do you feel like your residency helped you prepare for your ICU rounds?
Definitely, because it helped me. One of my rotations, was a head to toe approach as opposed to soaping up patients, which, head to toe is a kind of a soaping up patients as well. But that experience from residency program definitely gave me the background that I needed to be able to work up the patients, and then also the self-drive, self-motivation to learn. I had to come in at least maybe an hour, 2 hours sometimes in advance to work up these patients and identify the primary problems, because now in the ICU we had anywhere up to 20 patients during that time, and so I had to make sure that I knew what the pertinent issues were for those 20 patients. And so, being able to look over the drug regimen, knowing the literature as well to kind of make the supporting recommendations for these patients.
While building relationship with physician, because you got to know what are you able to offer, how are you clinically inclined, and so it sounds like a lot of changes. And then walk me through now you're not an ICU pharmacist and you're an internal medicine pharmacist. So how does that role, as the hospital expand, they're able to add more clinical pharmacists, right? So walk me through that journey.
So now going from being over 20 beds, this is now potentially 64 beds, even more, because during that time we were given the opportunity of getting a clinical critical care specialist on board who managed the ICU, and so it was a different aspect. Of course, there was not the regular rounding services that we're used to in the ICU, so I kind of had to, again, with the greater number of patients, focus on, okay, what is priority, any, of course, contraindicated medications, going to, fortunately here we have table rounds where there's case managers, the charge nurse, nurses, dietitian, and of course the nurse kind of presents the patient, and I'm listening in with, open ears to identify, at the same time looking at the drug regimen, so I can kind of catch any, if I notice anything, then I'll mark it down and I'll follow up with it after the table rounds. And so it's a totally different
routing structure and different group of team. So for those that don't really know, what does how is a community hospital different from like a large academic center, and the routing structure? Can you share a little bit about that?
So in the community setting, the majority of our physicians have their own personal practice. They have their own clinics. So you'll find it difficult at times to touch base with these physicians to make your recommendations. You have to call their office, wait for them to call back, as opposed to a lot of the larger academic medical centers. There's the physician there, medical residents that you can make recommendations to. Community, there's really not that, except in the ICU, because you have the intensivist that you can speak to, make recommendations. But on the floor outside of the ICU, you have to reach out to these physicians. You have to find them.
Yeah, so you hunt them down, essentially.
Yeah, pretty much.
And then you don't have the traditional rounding structure. Every hospital operates a little bit differently, and what Dr. Doe has alluded to, which is it's more of a table round with more case management and nursing. So you don't get the typical rounds, but you still may be able to hear something relevant, like discharge, or the patient needs certain things, or the patient going home health with IV antibiotics. So just so you can kind of listen in on that, but it may not be a traditional rounding.
Exactly. And during those table rounds, it's mainly to see, okay, does the patient have what they need to be discharged? And me as a pharmacist there, I'm trying to find ways to kind of help facilitate the patient to be discharged. Meaning that if the patient is able to tolerate oral medications, transitioning any IV medications to oral kind of helps facilitate that discharge process. And so it's a totally different mindset, because as opposed to focusing on acute, immediate issues at the time, you're making sure that the patient is able to kind of be transitioned out of the hospital.
Right. At that round, I mean, as a pharmacist on the floor, you still need to triage any acute issues, but at that round specifically, you're really trying to listen in more for like, okay, patient going home today or tomorrow, what do I need to do to help ensure that everything is good to go?
Exactly.
So can you kind of go through your day-to-day, like when you start your day, what does that look like for those that kind of want a glimpse of what you do?
So pretty much kind of similar to the ICU rounds. I'll come in the morning, look at my patients, look at any pharmacy consults that we have to manage, make sure I have when the labs are due and following up. And then my table rounds start at 9 o'clock, 8:30 in the morning for my IMU patients, because I am over the IMU patients, which is limited at this time. It's at max 6 patients.
And for those that don't know IMU, what is that?
Intermediate intermediate unit, which is a step down from ICU. So it's ICU, IMU, and then just regular floor patients. So I'll go in for IMU, again, review my patients, jot down anything that I see that may be a concern and bring it up during those rounds. And then during the table rounds, I'll listen in. If I notice any drug interactions, drug disease state interactions, that I'll mark it down after the table rounds, then I'll follow up. I'll call the physician. Sometimes I'll stay on the floor because they may be coming in, and then I can intervene with them there. I personally like face-to-face interaction as opposed to telephone calls, because you get to kind of build that rapport again, because when you see face to face, it's very different than just telephone. One is that the physician gets to see your face, know who you are, putting a name to a face, and in that process, it helps to build that relationship that's needed.
Yeah, and then
so after intervening, then I'll go back and maybe touch base on all the patients, make sure all my I's are dotted, my T's are crossed. And this is outside of any committees that I'm involved with. So as a clinical pharmacist here, I'm not just strictly doing clinical
pharmacy work.
Yeah, direct patient care. I also do indirect patient care, which is through involvement in various committees. Currently, I'm involved with the P&T, cardiology section, readmissions committee. There's many other committees I can think.
Safety meetings,
medication safety.
So yeah, one thing again, a community structure is a little bit different. Is that at our facility, we don't have a clinical manager yet. So a lot of our clinical pharmacists kind of take on additional community work, and actually that leveraged really well because in terms of building a relationship with physicians, because not all of them go, but some of them go. So that's kind of another avenue, and it actually builds a very strong administrative skills for our clinical pharmacists. So do you want to talk a little bit about, like, you mentioned already the number of committees you're involved with, but how being involved in committees help to build certain skill set for you?
So definitely communication is one thing, because, and especially interdisciplinary communication, because during these committees, there's nursing involved, physicians involved, other, respiratory therapists involvement, hospital administrators, CNO involvement. Communication is a very important thing, because you need to listen in, because if you're not at the seat of the table and they make some discussions around pharmacy, whatever is decided at the committee is decided. If you didn't bring up your voice to represent pharmacy, then what they say goes. But being there on the committee, listening for anything that could potentially affect pharmacy, we need to bring it up, because pharmacy plays a big role in the treatment of these patients in the hospital. And so one is having listening ears and speaking up when needed to. And the only way you're going to be able to speak up is if you know how your department operates, and being in close communication with your manager as well as your director.
Yeah, and I think that's a strong point. It's like being able to vocalize when, especially on things that pertain to pharmacy workflow, and that could be from operations to clinical or just in general, and having that representative voice, because pharmacy is represented in various organizations and organizational meetings, so it's important. And I think our clinical pharmacist here works in conjunction very well, and it kind of gives them that patient care, but also an administrative aspect. So to wrap up, what are 3 things that you find yourself very rewarding as a community clinical pharmacist?
The direct patient care, you oftentimes get to see patients turn around sometimes, especially for those that may be resource lacking, being able to help out in that sense. Try to get what they need, making interventions with physicians, because sometimes there could be a more cost-effective alternative.
Right.
So that is very rewarding. Also, having physicians call you because they need some recommendations. Being a part of the cardiology section committee, working closely with our cardiologists as well as our internal med doctors on the floor, helps to build that rapport, that relationship where they call me to ask me questions, when usually we're used to pharmacy calling the physicians because we need this, we need that, we need to stop this, but having them call you for recommendations is very rewarding as well. And making an impact in our department through these committees. this administrative duties is something that is needed in our department to kind of help make sure that we function well with the other disciplines, because it's not just pharmacy, it's not just the other departments outside of the hospital, but it's the hospital as one unit.
Absolutely, and then every facility is very different, but my experience in a large academic center where I've been actually through two, clinical pharmacists are not traditionally involved in kind of the administrative duties besides like their own little section of internal medicine or oncology, but being a community setting, you're basically what is it called? Master of none, jack of all trades. Essentially,
Exactly.
like even myself as a manager for operations, I dabble into the clinical quite a bit, just because again we all have to stretch ourselves throughout and help to fulfill patient care. So with that, that's a wrap. For those that are interested or have more questions regarding what does a clinical pharmacist in a community does, just post comments below and I'll try to answer them, or I'll refer them to Dr. Joe. And for those that are working professionals right now and just try to put one thing that you do that is fulfilling to you as a clinical pharmacist, we would love to see that too. Until next time, ciao.
Bye.